Welcome to the Lymphoma Research Foundation's update on relapsed refractory mantle cell lymphoma. I'm Donna, and I'll be the operator for today's call. During today's call, you will hear from an expert speaker, and you will have an opportunity to ask questions. If you have questions during today's presentation, you can ask them at any time in the Q&A box on the webinar interface. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on the screen. Please follow this link to complete an evaluation of this program and gain certification of attendance. If you are listening by phone, this link will be sent to your email at the end of the webinar. And now I'm pleased to introduce Jesse Brown. Jesse is the Associate Director of Patient Education at the Lymphoma Research Foundation. Welcome, Jesse.
Thank you, and thank you to each of you for taking the time to join us on today's update on relapsed refractory mantle cell lymphoma webinar. We'd like to thank our sponsors of this webinar, Bristol Myers Squibb, BeiGene, Kite, a Gilead company, Lilly Oncology, and Pharmacyclics, an AbbVie company, and Janssen Biotech. Before I turn the program over to our speaker, I want to briefly share some information with you on LRF. Access to expert disease information is so important, and we're thrilled to be able to bring you this educational program. LRF is the nation's largest nonprofit dedicated exclusively to lymphoma. Our mission is to eradicate this disease through investment in the most promising lymphoma research and to serve those impacted by lymphoma through quality education and support opportunities. As we continue to make progress in advancing lymphoma research, we also want to ensure that you have access to the latest information about your disease. The Foundation provides comprehensive disease and treatment-specific resources, programs, and services, all of which are offered free of charge and have been reviewed by lymphoma experts. Most relevant to today's call, LRF offers a variety of lymphoma-specific resources, many of which you can access at the bottom of your screen if you're utilizing the web link, or via LRF's website at lymphoma.org if you're on your phone. The LRF helpline can answer your specific questions about lymphoma, as well as discuss relevant treatment options and clinical trials. We also offer the Lymphoma Support Network, which is a one-to-one peer support program for people with lymphoma and their caregivers. We offer a variety of publications that have been reviewed by lymphoma experts to ensure you have access to the latest lymphoma information. Our mobile app, Focus on Lymphoma, is an award-winning app that provides patients and caregivers access to comprehensive content as well as unique tools to help manage your disease. Finally, we have launched our COVID-19 Learning Center to support lymphoma patients and caregivers through this challenging time. Please visit our Learning Center for access to webinars, articles, and other resources specific to COVID-19. I really hope you'll take advantage of some of the great resources and services that the LRF provides. If you have questions regarding what you've heard about today, or if you need information about relevant treatment options and supportive care resources, you can reach out to the Lymphoma Research Foundation through our website at lymphoma.org or by calling our helpline at 1-800-500-9976. We have a wonderful program planned for you today, and I'm honored to introduce Dr. Elizabeth Bankston. Dr. Bankston is a hematologist and oncologist, as well as an assistant professor of medicine at Dartmouth-Hitchcock Medical Center. In addition, she has served as an expert speaker on numerous patient and professional programs for LRF. Thank you so much for speaking at our program today, Dr. Bankston. I'll now turn the talk over to you.
Thank you. I hope you can all hear me. First of all, I'd like to thank Lymphoma Research Foundation for inviting me to speak today, but even more for all that they do for both research and for our patients who have lymphoma. It's so appreciated, and thank you so much. You have an amazing mission, and we appreciate it so much as physicians and as patients. And I'd like to welcome all of you. Often I do these in person, and it's hard to do them on the web. I'm sure you all are frustrated as well, but we'll do our best to make it as personal as we can. There will be time at the end for questions, and I look forward to talking with all of you then. So today I've been asked to talk about mantle cell lymphoma, specifically about relapsed refractory. I'd first like to tell you that I have no conflicts of interest or disclosures. And what I thought we'd do today is just to get everybody kind of on an even playing field. I'd like to just talk about some of the basics of lymphoma. How do we diagnose it? What are some of the prognostic tests that we have? And then what are some of the standard treatments for mantle cell lymphoma? How do we decide how to first treat our patients? Then we're going to move into the primary topic of the day, which is the relapsed mantle cell lymphoma, and how do we treat that? What are the roles for different types of transplants, such as CAR T-cell or Allergenix stem cell transplant, novel agents, and, the future is looking really bright, so at the end we'll have our sunglasses on. Some of the topics that we'll reach in the second half are the novel agents, which is kind of what all of the hype is about these days. We'll talk about Lanolidomide, Bruton, that should say Calibrutinib, not Calibrutinib, Bortezomib, also called Velcade, Autologous, Venetoclax, checkpoint inhibitors, and then I think everyone's pretty excited about CAR T-cell therapy and how that's going, and we'll talk about that as well. So let's start off just with some basics of mantle cell. We'll keep this short because many of you might already know about it. But this is what a circulating lymphocyte or mantle cell lymphoma cell looks like. It's not quite a typical looking lymphocyte. It looks a little abnormal if you are a pathologist because it has all of this extra light purple around here that normally wouldn't be there. That's what the lymphoma or mantle cell looks like in your bloodstream. And what we know about cancers is cancers develop from a normal cell. In this case, it's a lymphocyte. And normally these cells should divide, but they also have controls in them that tell them when to divide. So they don't divide out of control. What happens with a cancer is the DNA is damaged, and the cell then divides without any controls. There's nothing to limit the division, which ends up with a tumor. And that's essentially the diagnosis of a cancer or a malignancy. So this is what a lymph node biopsy looks like. If you just slice a mantle cell lymph node in half, you'll see it's basically just a sea of small lymphocytes. These are mantle cell lymphocytes, or mantle cell lymphoma cells, I should say, all looking very much the same, kind of a unique homogeneous population. Oops, hold on. There we go. And how does mantle cell present? Most patients are in the second half of life, not always, but most. There's a male predominance. And patients can just present with symptoms. They can present in all different ways, but some just present with night sweats or weight loss or fatigue. Some present with enlarging lymph nodes that they feel or their doctor feels. Sometimes a white count can be elevated, and a doctor catches that on a blood count and draws attention to it and works it up a little further. Sometimes if the marrow is involved, it can actually result in low blood counts on your blood count, which come to a provider's attention. As you know, mantle cell may involve a large spleen, so sometimes that's felt or symptomatic. And then it also commonly involves the GI tract, so sometimes diarrhea or change in bowel habits or xenon colonoscopy. All of those ways it can present. How do we diagnose it? How do we know it's mantle cell and not another kind of lymphoma? Well, it's a combination of a lot of things. First of all, we have to look at the bone marrow biopsy or the lymph node. And what we're looking for is a classic flow cytometry. That is the markers on the outside of the lymphoma cell. I have a picture coming up, and the ones that a mantle cell lymphoma would have are CD19, CD20, and CD5. But in addition to that, a few other lymphomas can look like that. So in addition, kind of the sine qua non is expression of either Cyclin D1 or SOX11, or both. And Cyclin D1 results because of some DNA damage or chromosomal damage in the cell. Essentially, chromosome 11 gets tangled up with chromosome 14, and that results in the Cyclin D1 protein expression. And so it's because of this translocation that you end up with mantle cell in a lymphocyte. And in some cases, patients have SOX11 expression, which is a little less common, but you can also see that one as well. So all of these things together give us the diagnosis. And here's a beautiful lymphocyte. I just love these photographs. But you can see these little proteins kind of protruding from the lymphocyte. And those, imagine those are kind of like the CD markers. Some of them would be CD, they're all different, and some are CD19 or 20 or 5, and that's what we're looking for to diagnose the CD markers that I just talked about. And then this is what a lymphocyte looks like. Mantle cell lymph node looks like. On the right at the top is a normal lymph node, and you should see these follicles kind of around the periphery. That's normal. Here, the mantle cell of the follicle, which is quite slim if you look at the normal one, but on the mantle cell lymphoma on the left, you'll see that mantle zone is what that's called, is expanded and much thicker, and that's how we know it's mantle cell lymphoma. You see a very expanded mantle zone. So, I'm not going to review pre-treatment workup because I think most of the people who are attending this are already past that, and probably you've seen PET scans with your providers, so I'm not going to spend time with that. But what about prognosis? So there are some things that help us kind of figure out how aggressive a patient's mantle cell might behave. And the WHO has now defined a subset of mantle cell called leukemic non-nodal. And that's a group of patients, about 20% of all mantle cells, that don't have a lot of lymph nodes, usually an elevated white count and a big spleen. They usually do not have SOX11 expression. And these patients actually sometimes do quite well and may not need treatment. They can be watched in many cases without treatment, often for years. So it's actually a good thing to have the leukemic non-nodal. And it's probably about 20% of all the cases, maybe a little bit less. And then there are a few things that make a mantle cell more aggressive. There can be a blastoid, a pleomorphic variant. A Ki-67 stain can be higher. I'll come back to that. There's a scoring mechanism that your provider might use just to give him or her an idea of the characteristics of your mantle cell and how it might behave over time. And then what's really on the horizon is going to be probably the most important thing in years to come is molecular markers. And which molecular markers, those are basically genes that are turned on or turned off. Which ones make a lymphoma more aggressive and which one might actually make it less aggressive. So we're kind of just on the horizon of using molecular markers. And then the step after that is that once we've identified the molecular markers, the next step is going to be how do we target those and possibly, treat specifically with a specific marker in mind. And we're not quite there yet, but it'll come. Whoopsie, what did I just do? Okay, sorry about that. I keep hitting something on my computer. So Ki-67 staining I mentioned. Ki-67, it's a stain that marks cells that are actively dividing. So it's a brown stain in these instances. And we know that if in a mantle cell biopsy, if more than 30% of the cells are dividing, that marks a more aggressive mantle cell. So if you look at these slides, Burkitt's lymphoma, which is our fastest growing lymphoma that we have, you'll see all of those cells are dividing. They're all brown. And then in the middle is a mantle cell example. And honestly, the pathologists kind of eyeball this, but they'd probably eyeball that as between 30 and 40%, so a little aggressive. But the majority of cases are less than 30%, but if it's over 30%, we just know that that mantle cell case may be a little more aggressive over time. I mentioned the Mipi score. The Mipi score only applies when a patient's first diagnosed. It does not apply, it's not as though if you're now further on in your course, you can use this Mipi score at any time. So it can only be used when you're first diagnosed. And your doctor or provider might know what yours is or how to interpret that. Okay, so it's time to treat a patient. We're going to talk about what are the best options for first treatment, what is a complete remission, what is a molecular remission. Then we're going to talk about what do we do after that, Rituxan, autologous stem cell, Allergenix stem cell. Then we're going to get into the relapsed and refractory cases. So, selection of first treatment. Always best to consider a clinical trial if you have an option. Clinical trials have been proven. Patients on clinical trials actually get better care because there's so much attention for patients that are on clinical trials because they're so carefully monitored by the FDA. And there's a team of research nurses and basically team of nurses as well as people acquiring data that are watching you. And every I has to be dotted, every T has to be crossed. So a clinical trial is always a good option. As I mentioned, some cases watch and wait is an option. And then for the most part, first treatment is usually a chemotherapy or immunotherapy option. Watch and wait we talked about. Watch and wait is for the leukemic and non-nodal type most commonly, although we know that patients can be watched without doing any harm if it's unclear if they need treatment. So it doesn't do harm to wait a few months before treating a patient if you have mantle cell lymphoma. So what's the goal of therapy? Our goal, we know mantle cell right now, we don't think it's curable with the exception of a transplant from another person, an allogeneic stem cell transplant. However, that could change in the future. So what are we trying to do? We are trying to give our patients the longest remissions with the least toxicity and prolong their life as long as possible while maintaining a good quality of life. So how are we going to accomplish that? First of all, we need to figure out what's the best treatment plan for a patient. And the major question that comes up is, should a patient get an autologous stem cell transplant in first remission? This is a difficult question that patients need to talk to their providers about and decide together. It's basically a combination of looking at the patient's age, their performance status, what other comorbidities or other medical problems they have, what their organ function looks like, is their heart good, are their kidneys good? What are the characteristics of the patient's mantle cell? Do they have any of those more aggressive characteristics? And of course, the patient's wishes. You know, an autologous stem cell transplant is a very aggressive treatment, 3 weeks in the hospital at most institutions, followed by 2 to 3 months of recovery, if not more. So it's a big quality of life question as well. So that's something you have to decide with your providers. So talking about patients first who are non-transplant candidates, and I'm going to skip a slide here, but patients that are determined either by the provider or by the patient themselves that they don't want a transplant, these patients have options. And over the years, it used to be R-CHOP chemotherapy years ago that was always the recommended treatment. And based on these two trials, the STILL trial and the BRIGHT trial, that standard of care has changed. And now bendamustine with rituximab, R is rituximab, is the standard of care for upfront treatment in most cases if you're not on a clinical trial, or some variation of bendamustine and rituximab. And that's because these two trials both proved that although bendamustine and Rituxan didn't help the patients live any longer, the survival was the same with both regimens. But with bendamustine and Rituxan, there was less toxicity, and the progression-free survival, that's the period of time that you're in remission before you need your next treatment. That's called progression-free survival, was better with bendamustine in both groups. So for the most part, standard of care for patients not getting a transplant is going to be some variation of bendamustine and Rituxan in most cases. And there's been ongoing trials adding different things to them, seeing if we can even get it a little better. But bottom line, bendamustine and Rituxan had the least toxicity and probably the best, or definitely the best response, but overall survival might have improved as well. Now, what about the young, fit patients? These are patients that you could consider for an autologous stem cell transplant. The first thing we need to do is get you in remission before we do a transplant. So you need to have a patient in remission, and I have a slide coming up defining exactly what remission means. But so here we're going to use more aggressive treatments in these patients. And there are a few options depending on the institution which one you might choose. The Europeans tend to use the R-CHOP with RDHAP, although that's used in the United States as well. In the United States, I think mostly you'll see the Nordic regimen, which is tried in Protrude. It's been out 15, 20 years. And that's basically a regimen of high-dose CHOP along with high-dose cytarabine. Aracia and cytarabine are the same things. And then once in remission, you get a transplant. Another commonly used regimen before transplant is out of Dana-Farber. That's bendamustine and Rituxan for 3 treatments, followed by high-dose cytarabine for 3 treatments, followed by autologous stem cell transplant. And the goal of these treatments is to get the patient into a complete remission and then follow it with a transplant. And we know that a transplant improves progression-free survival. It gives you almost 2 years longer that you're in remission before you need your next treatment in most cases. That's an average. So let's see, skip that slide. So basically, here are our options. If you're young and fit, clinical trial, the Nordic regimen with a transplant, the bendamustine and cytarabine with a transplant, and then there's also our hyper-CVAD, which I'm not going to talk about. That's been developed out of MD Anderson. It's toxic, not used as much as it used to be. I used to use it a lot. I'm using it less now. But that, if you use hyper-CVAD regimen, that does not include a transplant. And then the options under the non-transplant candidates are going to be clinical trial, R-CHOP with or without cytarabine or Velcade, bendamustine with or without cytarabine and Velcade, and then one that I didn't talk about, but I have a slide later, which actually got misplaced, which of course I noticed when I practiced after I submitted my slides, but it's coming up, which is Rituximab with Lanolidomide, also called Revlimid. Very easy regimen to take with excellent results. So if we're not going for transplant, that's another good regimen to consider up front. Okay, so we chose one of those regimens, or possibly another that I didn't list, and you finished usually 6 cycles is usually what we do. Now we look for remission. Complete remission means that there's no evidence of the disease to the best that we can see. So that means that your PET scan or CT scan, although most people are doing PET scans, is negative. A bone marrow biopsy is negative. And then if you have lymphoma in any other site, maybe in your colon, maybe in your CSF, your spinal fluid, maybe somewhere else, that also doesn't have any disease in it anymore. That's now a complete remission. And we've taken that a step further now, which is what's called a molecular remission. A molecular remission has come up because our technology has now gotten good enough to literally look for DNA of mantle cell in the patient's bone marrow or bloodstream. So it's even a closer look to see if there's any signs of the lymphoma at all that's left. And there are a couple ways to test for a molecular remission, but the most common in mantle cell is done by PCR. It's a molecular technique, looking for any signs of mantle cell lymphoma in either the bone marrow or the bloodstream. And the reason I bring this up is because it's very appropriate, or I think that's my next slide. Nope, it's not. It's coming up, but we now have a clinical trial that uses molecular remission or minimal residual disease status to determine the next steps for a patient, and I'll come up with that in just a minute. So what's next? We have you in remission. For a young, fit patient, you have the choice of moving forward with an autologous stem cell transplant, which has shown to prolong progression-free survival, or maintenance rituximab, which has been shown to prolong progression-free survival and overall survival. Or you can do both in a young patient. In an older patient who's not or a patient with medical problems who's not a candidate for autologous stem cell transplant, then maintenance rituximab is recommended. That's 1 dose of rituximab every 2 months, now for 3 years. It used to be recommended for 2 years, but now we recommend it for 3 years. Okay, I'm going to skip these. These are the differences between autologous and allogeneic transplant. And let me just say, the only thing that's the same between them is the word transplant. They're completely different, even though they're both called transplants, but they're very, very different. Okay, autologous stem cell transplant should be at least considered in all eligible patients. It should be discussed whether you choose to do it or not. And we know that the patients who are PET negative or MRD negative are going to do best with an autologous stem cell transplant as compared to those that don't achieve a complete remission. Here's the trial that I was mentioning. Every time you see this little sun with his reading glasses on or sunglasses on, that's a clinical trial on my slides. So this is a trial that's a nationwide trial. It's rapidly accruing patients, and it's a great trial. So what this trial is asking is, does every patient who gets an autologous stem cell transplant really need one? Do they really benefit? So what this trial does is takes patients who are in complete remission. They then test them for MRD, or minimal residual disease, using that DNA test in the blood or bone marrow that I mentioned to you. If they are minimal residual disease positive, if there's still some DNA circulating that we can see, all of those patients will go ahead and get a transplant. If there's no disease evident and their minimal residual disease is negative, then they're divided. Half of them will get the transplant, followed by maintenance Rituxan. The other half are just going to get maintenance Rituxan. And what this trial is asking, which is a really, really important one, is it really beneficial to do the transplant if we don't even see any DNA signs of the lymphoma being there anymore? And we won't know that until this trial matures. But it's asking a very important question, and I've been enrolling most of my mantle cell patients who are eligible on that trial. There's another trial going on in Europe, called the Triangle trial. This is also looking at maintenance therapy and transplant. And this one's looking at different R-CHOP combinations, moving Obinutuzumab into front line, then a transplant, and then instead of maintenance Rituxan, using maintenance Obinutuzumab. That's available in Europe. So I just started mentioning Rituximab. I won't talk about how it works, but I will tell you that since we added Rituximab to chemotherapy in lymphoma, across the board, just by adding Rituximab to these old chemotherapy regimens that we'd had around for years, survival increased by 10%. That's pretty much unheard of in a cancer setting, where just by adding one new drug, everybody benefits. So we love Rituximab. It's like water in our world, and it was FDA approved in, I think, 2002, if I recall. I don't remember when it was FDA approved for mantle cell, but it was for diffuse large. It was 2002. Okay. Maintenance Rituxan. As you know, if you've been treated, you got Rituxan as part of your treatment. And then maintenance Rituxan has been proven to prolong survival if you received R-CHOP. It also prolongs survival if used after an autologous stem cell transplant. That's number 3. The data is still out whether it prolongs survival or has an advantage if it's used after bendamustine and Rituxan. That is very controversial as to whether maintenance Rituxan should be used in a patient who's had bendamustine Rituxan. One large trial, the STILL trial, showed that it did not offer an advantage, but it's still often commonly offered to patients, and many patients get it after bendamustine and Rituxan. There's another smaller trial that suggests maybe it does benefit, so it's up to you. But the recommendation is maintenance Rituxan would be 1 dose of Rituxan every 2 months for 3 years. That's maintenance Rituxan. Okay, now there are more trials ongoing, and you all can look at these later. There's trials, looking at all different sorts of things that I have here. Here are 3 different trials kind of looking at bendamustine and Rituxan, and what if you add Revlimid in with the maintenance Rituxan, what if you add Velcade in. So all different types of trials that are ongoing. And this is the one I told you that I misplaced slide. Sorry, this slide should have been earlier, and I apologize for missing that. But this shows a trial, and unfortunately these columns, when I moved it from my computer to send it to LRF, these columns changed on the slides. That happens sometimes with PowerPoint. But anyways, this should be progression-free survival, and this should be overall survival. But basically, this is a trial of Revlimid and Rituximab in frontline, and it's a non-chemo trial. Revlimid is a pill, also called Lanolidomide, and it's then followed by maintenance Rituxan. And these results were excellent, and no chemotherapy was used. So it was just immunotherapy and a novel agent, Revlimid or Lanolidomide. So this would be a great option for a patient who's not a transplant candidate. Good results, although very small trial. Okay, so you're in remission. Life is good. Hopefully that lasts many, many years is our hope for anyone. But then at some point, clouds are going to come. And in most cases, mantle cell will recur. So now what? Treatment at relapse. So how do we decide what to do? And that's kind of the gist of this trial, or this talk. What are we going to do if patients relapse? And I have to say, if there's one take-home message, there is no standard. If you go to 5 different doctors across the country, you'll probably get 5 different recommendations of what to do. There is no best known kind of second-line treatment that's mutually agreed upon. But I'm going to go through lots of options because we should make the decision on how to treat a patient looking at the patient themselves. What are their other comorbidities or medical problems? What prior therapy have they had? How long have they been in remission? And then are they a candidate for CAR T-cell or an allogeneic stem cell transplant should be considered as well. So options, always clinical trial is one that we always push, and with good reason, because you get very good care and hopefully cutting edge. Let me just tell you that if we are to write a clinical trial and submit it to the FDA, we have to prove, in order to get it approved, we have to prove that what we are offering or what we're submitting or going to try, we have good reason to think it's better than what is already being done. A clinical trial will not get approved unless we have a really good reason to think it's going to offer an advantage to the patient. Sometimes we're wrong, but we go into a trial with the intent that it's going to help a patient and be better than what we're already doing. And the FDA is very strict about that. So, bright future ahead. Okay, clinical trials we talked about. Sometimes, and I have a patient right now, we use chemotherapy again. I had a patient, for instance, who I'm treating right now, and he got bendamustine or Rituximab 6 years ago, was in remission. His disease came back, and he said, "Hey, doc, I want it again because it worked so well, and before I move on to some of these other agents, I want to try it again because it was easy, it worked well, and I want to save those other agents." And we talked about it, and that's what he wanted to do. So we know that going back to chemotherapy, especially if you hadn't already had bendamustine, bendamustine works really well, 90%, 80%, 70% in patients who had not already had bendamustine. It still can work. So chemotherapy is an option. Having said that, we know that a transplant from yourself, an autologous stem cell transplant, is not as good in the relapse setting as it is in the first line. So if you're going to do an autologous stem cell transplant, that's a transplant from yourself, the best time to do it is in that first remission like we talked about already. Doing it later, we know the results it doesn't offer the same amount of benefit. So wouldn't do that. So now we have targeted therapies. So targeted therapies have many names. You'll hear them called small molecules or novel agents or inhibitors. On the left is your atomic bomb. That's kind of what chemotherapy is. Chemotherapy goes in, it kills your lymphoma, but it also has a lot of collateral damage. It's going to kill a lot of your normal cells as well, like your hair follicles, for instance. That's why your hair might fall out with chemotherapy, or your taste buds. So chemotherapy is going to kill good and bad cells. The novel agents are more like sharpshooters, trying to target just the lymphoma cells, leaving all of your other cells alone, and hopefully minimizing collateral damage and side effects. So we have a lot of different targeted therapies. We'll start with the BTK, of Bruton Tyrosine Kinase Inhibitors, and talk about that, Ibrutinib, which I'm sure everyone's heard of. There's the new anti-CD20 antibodies, Obinutuzumab and Ophetuzumab. Ophetuzumab is actually on short supply now, but Obinutuzumab has been found to be helpful in patients who've already had a lot of Rituximab. It's basically, imagine a more specific Rituximab. And sometimes if a patient's had a lot of Rituximab, their cells will become immune to it. It won't work anymore. But changing to Obinutuzumab, a different CD20 antibody, you can still sometimes get a response. It has more neutropenia involved with it too. We'll talk about Lanolidomide, proteasome inhibitors, Autologous, Venetoclax, and CAR-Ts. CAR-Ts, the exciting one. Okay, I'm going to skip this busy side and move to this one. So we're going to talk about the Bruton Tyrosine Kinase Inhibitors. That's Ibrutinib. So imagine what you're looking at here is this is the membrane of the cell. So imagine a cell, and this membrane is going to be going around in a circle. And on that membrane is something called a B-cell receptor. That's this green Y that you see in the middle of the membrane. In lymphomas, these B-cell receptors are often always turned on. And when they're turned on or stimulated, it results in a cascade or dominoes of all of these little round things. I wish you could see my pointer, but you can't. But all of these different kinases are basically a cascade that ultimately end down here where your DNA is, which is in the nucleus. And it tells the cell to divide. So whenever your B-cell receptor is stimulated, it results in this domino effect, which results in the lymphoma cell dividing. What Btk inhibitors do, you can see the Btk up here at the top along the membrane there. Ibrutinib basically wipes out that kinase, that enzyme. And by taking out that domino, it breaks the cascade, and it can no longer, even though the B-cell receptor might be stimulated, it no longer can get to the nucleus or the DNA, telling the cell to divide. So that's how Bruton Tyrosine Kinase Inhibitors work. Ibrutinib was the first one approved. And so it was FDA approved almost 8 years ago. I can't believe that, for mantle cell. It's a pill, and it was based on a trial of 111 patients. What's important to know is these patients were heavily pretreated. They've been through a lot of treatments already. But despite that, there was a 70% response rate. That is an outstanding response rate in patients who've already received a lot of treatment. It's also relatively well tolerated. It's not a cure, but it's a good option. And we know that using it earlier is better than using it later. However, it's hard to know. It's not yet approved for frontline therapy. It could be in the future, but it isn't right now. Ibrutinib side effects. GI side effects, nausea and diarrhea are one. It can drop your blood counts, but not as low as like chemotherapy drops your blood counts. It's usually a mild drop in blood counts, not a dramatic one like you see with chemotherapy. It can increase your risk for infections. There's a risk for bleeding or bruising on Ibrutinib, and there were also reported life-threatening bleeds. It can worsen your kidney function. And then in a few patients, it can cause atrial fibrillation or irregular heartbeat. So the nice things about Ibrutinib was even in high-risk patients, some of those risks we talked about earlier, it still has a good response. So let's see, what else do I have working on? Okay, we're going to go on that one. Calibrutinib is a second-generation Btk inhibitor. So this is the second one that was FDA approved. And basically, it's just a little bit more specific. So Btk, or Ibrutinib, is not perfectly, it's not a perfect inhibitor of Bruton tyrosine kinase. It also turns off a few other enzymes, and that's why you get side effects from it. So Calibrutinib is even a little more specific to just the Btk enzyme or kinase, and it has a few less side effects. It seems to have less cardiac and bleeding side effects than Ibrutinib, so it's good for patients who are on blood thinners or who have cardiac risks or arrhythmias, like atrial fibrillation or something. It also has excellent response, just like Ibrutinib. And now there's two more Btk inhibitors. Zanubrutinib has been FDA approved, and just this week, Relapsed has been FDA approved. I think most of us tend to use Calibrutinib and Ibrutinib just because we're more familiar with those. There's a trial of using Calibrutinib with bendamustine ongoing for frontline treatment now, looking to see should we move it into first-line therapy, which we don't know yet. Okay, so, sorry, I'm just looking at a question. The future of Btk inhibitors or Bruton tyrosine kinase inhibitors are probably combinations. There's a nice trial of Ibrutinib with Rituximab, which had this is in second-line treatment, 88%, or not first-line, I should say, relapsed disease, 88% response rate, 44% complete response rate. That's really high for a not first-line treatment. The other thing that this trial found is that unlike chemotherapy, Ibrutinib continues to work for several months. You still get a better response as time goes on. So the immediate response, I think that was at 6 months, I can't remember, it was 44%. But then as they waited, the complete response went up as the months went on. Kind of versus chemotherapy, you see your best response immediately. When the chemo's done, that's when you're going to have your highest complete response rate. But Ibrutinib works differently, and it seems to just keep improving the response rate as time goes on, at least until it doesn't work anymore. The Philemon Trial, I actually love the name, the Philemon Trial, is an interesting trial where they added, it was Ibrutinib with Rituximab plus Revlimid, also called Lanolidomide. That's a pill. That also had a really good response rate with a complete response rate of 56%. Really nice results. I want to use this slide to highlight one point that's really important. So here you see two trials, and you see a response rate on the top of 88%, and you see a response rate on the bottom of 76%. And if I were a patient, I'd say, well, geez, look at that. I want the Ibrutinib and Rituximab because that's 88% response rate. Why on earth would I want a 76% response rate when I can have an 88? Unfortunately, unless the regimens are compared directly to each other, you cannot say that one is better than the other unless you compare them head-to-head. Now, if one response rate is 90% and another's 30%, well, that's a little different. But something like this, we don't know how many regimens those patients had already had in each trial. We don't know, were those high-risk patients or low-risk patients? We don't know, did they have heart disease? Did they have bad kidneys? We don't know anything. You just don't know if you can compare those results head-to-head. So be careful when you're looking at these trials. Unless there's a huge discrepancy between results, you can't necessarily compare one trial to another trial that are published separately. So it's really important to understand that. Okay, there's another gene. We talked about the Bruton tyrosine kinase gene. There's another gene called the Bcl2 gene, and I like to call this the fountain of youth gene. Some of you may know that the majority of our cells are programmed to die at some point, okay? And they die through a process called apoptosis. So most of our cells, like think of our skin, they're only supposed to live so long, and then the new skin underneath comes up. The old skin sloughed off, those cells die, and the new skin comes up. Well, our whole body is kind of like that. However, there's a gene that's normally turned off. If that gene, it's called Bcl2, is turned on, then those cells lose the direction that they're supposed to die. They actually become immortal if the Bcl2 gene is turned on. And that's what happens in mantle cell lymphomas. Some mantle cell lymphomas have the Bcl2 gene turned on, which essentially tells those cells never to die. It's probably in very simple terms, but they never are programmed to go through apoptosis now. Hence, they live longer, making it harder to kill them. So what if we inhibit that gene? What if we're able to turn that gene back off the way it's supposed to be in the first place? That's what a new drug called Venetoclax does. It inhibits or turns off the Bcl2 gene. It basically tells the cells to die again. This drug had a response rate of 75% with a complete response rate of 21%. And even in high-risk patients like TP53 and patients with a high Mipi score, it still had a good response. Venetoclax, I've used a lot of it for mantle cell, but also CLL and acute leukemia it's used as well. And it's really well tolerated. Can drop your blood counts a little, and there can be some diarrhea. But for the most part, Venetoclax is very, very well tolerated, very few side effects. So it's a nice drug to try. And again, I think it's the same. Yeah, the story's the same. The future is probably in combination treatments. We just need to figure out which combinations. For instance, this Bruton and Venetoclax trial had a good response rate, a high CR rate, high complete response rate of 63%. What we don't know, that's great, but what we don't know is that better than using them sequentially? Like if you use one, like a Bruton up front, for instance, and then when your disease starts to grow, you either switch to Venetoclax or add in Venetoclax. What we don't know is it better to do sequentials, or is it better to kind of hit the mantle cell lymphoma with everything all at once, and maybe that makes the remission even longer? We just don't know. So all of these things are being teased out, and it's frustrating for all of us because there are no good final recommendations for relapsed disease. I'm watching the time. I actually think I'll be okay, but we just have a couple more to talk about, and then we're moving on to talk about the CAR T cells. So Lanolidomide, or Revlimid, is a pill. We honestly don't know how it works, to be quite honest. We call it immunomodulatory. It affects what we call the microenvironment. There's lots of different ways we think it works. It's also used commonly in multiple myeloma. But it had a really good response rate when combined with Rituximab. And it's the one that I mentioned earlier that would be a really good non-chemo regimen for a patient, first-line treatment that for a patient that didn't want a transplant. It's a good option. And it also, even in heavily pretreated patients, these are the 92% and 77% here. That's in untreated patients. But even in heavily pretreated patients, pretty good response rate, 30 to 40%. Not as high as some of the others we saw, but it's still a good response rate for second line or more treatment. And we can increase that response rate if we combine it with Rituximab. Idelalisib, in the interest of time, I'm going to skip. This is probably going to be best used in combination. It's a very well-tolerated pill that also blocks the B-cell signaling, that kind of cascade that I showed you under the Brutonib. That's an option. And then Velcade or bortezomib has been FDA approved for quite a while now. And that by itself isn't great, but in combination, probably that's where that option lives, is in combination with others. Okay, if your heads are spinning, I completely understand. So, but the future's bright. We have sunglasses on. Let's talk about, here's a couple more drugs. Neither looks good alone. Obinutuzumab and CDK4/5 inhibitors. They don't look great by themselves, but they might really have a role in combination. Checkpoint inhibitors. So checkpoint inhibitors, or in lymphomas, it's mainly nivolumab and pembrolizumab. These are the ones you hear about on TV. So these have, revolutionized the treatment of lung cancer, kidney cell cancer, melanoma. Amazing, amazing results. Results in lymphoma outside have been great with Hodgkin's, not as good with mantle cell, but they might really be an option in combination with something for the future. So I would keep my eye on the checkpoint inhibitors. And basically what they do, cancer cells are so tricky. People always say, why can't we cure cancer? By the way, I can stay a few minutes. I see I'm going longer, but I can stay a few minutes for your questions. People are always saying, why can't we just cure cancer? Well, it's because cancer is it can masquerade. Here's your tumor cell, or not yours, but a tumor cell over here. And this is a T cell that's supposed to, along with another cell called a dendritic cell, these two kind of dance together, and they're supposed to be able to kill a tumor cell. They should make a tumor cell implode. They should recognize it as a bad player and essentially just lyse it, make it just self-implode. That's what a normal immune system can do, or should do. But what these little tumor cells do, which is so tricky, this didn't magnify very well, but you see these PD-L1 and PD-L2 little markers? These are markers that are on our normal cells, which basically tell the immune system, whoa, I'm a good cell, don't kill me. I'm you. I'm good. This is me. I'm not the one you want to kill. Well, some of these tumor cells have figured out how to put this PD-L1 and PD-L2 marker on themselves, hence tricking our immune system to not kill them. And so what these checkpoint inhibitors do is they block this. They're PD-L1 inhibitors, so they block this here, so now the cell goes, you are a bad guy. I am supposed to kill you. You were trying to trick me, but it didn't work, so I'm going to make you self-implode. And that's what checkpoint inhibitors do. This is a picture. I love these pictures. This is a T cell in pink and a dendritic cell in the aqua color. Just think they're beautiful. Pretty amazing, our immune system. Okay, CAR T cells. So CAR T cells are really, CAR stands for chimeric antigen receptor cells. The idea behind this a CAR T cell treatment is to get our T cells to recognize our lymphoma. For some reason, the lymphoma has tricked the T cell into not being killed, and for whatever reason it is. So the way this works, and I think a picture's worth 1,000 words, I'm going to move towards this. Oops. Yeah, I'll do this slide. What happens is a patient has their T cells, some blood drawn off, where we collect their own T cells. They then are sent to the pharmaceutical laboratory, whichever product we're using, and there the pharmaceutical industry takes those T cells and modifies them and put something on the outside of them here where it will attach to their tumor cells. Okay, so they have a new receptor out here that wasn't there before, that is modified to attach to mantle cells, mantle lymphoma cells. The pharmaceutical industry then expands them or grows them so that there's a bigger number of them, and then deliver them back to the hospital, and they're infused into the patient. And basically, it's an infusion of your own cells that have been modified to attack your lymphoma. Now, when those cells go in, we've had, I'll show you the success rate. They're very successful at killing the lymphoma, but it also creates a huge immune response because you're infusing these very, very active immune cells. There's your T cell now recognizing your tumor cell. Very similar. This is the new marker on it, now being able to hook onto the tumor cell and kill it, where it couldn't do that before. This downside of a CAR T cell is the toxicity. This like revved up immune system that we're reinfusing for the first couple weeks can cause some neurotoxicity, basically inflammation of mainly the brain, and that can range from just headaches to some difficulty thinking to a seizure, and in the worst case scenario, actually life-threatening brain swelling. And we've learned through trials how to manage that and so that patients don't die from that. And we've done remarkably well at managing that with CAR T-cell therapy. The other side effect we watch is cytokine release syndrome. That basically looks like a patient has a really, really bad infection. They'll get fevers, low blood pressure. They look what we call septic, which is just a really bad infection. Those patients are in the ICU. But we've learned to manage that too. We give patients steroids. We give them an anti-IL-6 infusion called Autologous. And with that, we've gotten pretty good at managing these side effects. Patients can still get them, but we're very keen to how to catch them at the very first sign and catch them before they get too advanced. I'll show you the results in a minute, but the last toxicity is the financial toxicity. A CAR T-cell treatment for one patient runs between $300,000 and $450,000 per patient. That is something that our medical system probably cannot support forever. Huge financial toxicity that will need to be addressed in the future at some point. But having said that, sorry, these slides were not, those two were switched. Here are the results. In mantle cell lymphoma patients using the Kite therapy, this was the trial that gave them FDA approval. There were 60 patients. You can see it's given even in older patients. The age range was 38 to essentially 80 years old. They got one treatment of these modified CAR T cells. The response rate was 93%, so almost everybody mantle cell improved. The complete response rate was 2/3, completely gone, mantle cell. And so far, that seems to be lasting pretty long. At 12 months, the progression-free survival, meaning the number of patients who are still in remission, essentially, is about, well, let's say 2/3, we'll be optimistic there, 61%. The patients that are still alive, and these were patients who'd been through everything. And 83% of the patients with mantle cell who got a CAR T cell are at least still alive. That's really remarkable given how many treatments they'd already been through. And as I mentioned, these side effects, we're really treating them much better. They got almost everybody got low blood counts. About 1/3 of the patients had infections. The cytokine release syndrome, which is that like septic-like picture, just 15%, and the neurotoxicity, 31%. And again, we know how to treat those pretty well. Not that there's not risk, but doing very well. So putting it all together, we are running late, so I'm going to, this is just a summary of the things I've said, but I'm going to pass on that and finish at the picture of Dartmouth, and I finish every one of my lectures with a picture of my parents, to whom I owe everything. If it weren't for their sacrifices and wisdom and guidance, I wouldn't be where I am today. So I always like to remember them. And now I'll open it up, and I'm happy to take your questions. Your brains are probably spinning, but you will get to be able to, with that link they're going to send you, you can kind of go back to the parts that interest you and listen again. And are you there, Jessie?
Yes, I am. Thank you so much for that, Dr. Bengtson. It was extremely thorough, and I know we've gotten some great questions coming in, but like she said, if there's anything you want to revisit or review, or if your question wasn't answered, you can always rewatch this as it might have been addressed at another point. So I'll just get started with one of the questions we have that came in. We'll probably just go 10 minutes over the time, just in case any of the audience is knowing. But Dr. Bengtson, does Venetoclax cause a worse response to subsequent CAR T?
So those are questions that we don't know. The question comes up, and it's been questioned with both Ibrutinib and Venetoclax as to does the mantle cell become more aggressive after your mantle cell has seen or been treated with one of or both of those? And that question's been raised, and I don't think we know the answer to it. CAR T-cell therapy is definitely too new, and the numbers are too small to say anything for sure about those. But kind of flipping that question around, we also don't know if it's true that lymphoma that's been treated with Ibrutinib becomes more aggressive after it's had Ibrutinib. Those are questions and ideas that have been tossed about that we just don't know for sure yet. So unfortunately, I can't give a definitive question to that.
And our next question is, does a patient need to be in remission to do CAR T?
Oh, that's a really good question. Thank you for that. No, that's the wonderful thing about CAR T-cell therapy. You cannot do CAR T-cell therapy if a patient has no disease at all. So, because it needs to have something that it's going to attack. So if you're in complete remission, it's not going to be as effective. But so the time to do CAR T-cell therapy is you actually need a patient with some disease. That's probably an exaggeration what I just said, so let me step back. If a patient's in remission and has no evidence of mantle cell lymphoma at all, that's not the time to do CAR T-cell therapy. The time to do it is when you have evidence of disease. You get the CAR T-cell therapy process going, because that can take up to 6 weeks from start to finish, getting those cells expanded and everything. But you can't do it when a patient's in complete remission. They have to have had relapsed disease to move on to CAR T-cell therapy. And at the present time, they have to have had 2 prior treatment regimens per the FDA before they'll consider doing a CAR T-cell in a patient. They've had to have failed 2 other regimens before it. So I hope that answers that question.
Yeah, that's great. Thank you. Our next question is, does everyone with Cyclin D1 rearrangement have active mantle cell lymphoma, or can it be indolent, or can it just mean a tendency towards mantle cell lymphoma but not active disease?
Well, you guys, these are good questions. So Cyclin D1 defines the expression of Cyclin D1. Occasionally can be seen in other lymphomas. But so I guess let me try to answer that question in a different way. If a patient has mantle cell lymphoma, even if it's an indolent, if it's one of those good mantle cell lymphomas like the leukemic non-nodal, those patients still are Cyclin D1 positive, and they should behave well. When the patient's in remission, we usually can't find the Cyclin D1 anymore. It doesn't mean that it's not there, because eventually most patients' mantle cell will come back again, but we just can't see it. We can't measure it. It's beyond what we can see when a patient's in a molecular remission. But so I'm not. Is that patient? Whoever asked that question, can you tell me if I just answered your question? Because I'm not sure I understood exactly what you meant. Sounds like a good question, but I'm not sure I answered it properly. Do you have anything there?
I'll let you know. I'll let you know if they come in.
Okay.
But for now, we'll jump on. Someone had a question. Has COVID changed any of your treatment recommendations?
Very good question. Oh, COVID's been so hard. As you probably might be aware, because you are all are informed population, Rituximab knocks out your B cells, and your lymphoma cells are B cells. Your mantle cells are a cancerous B cell, essentially. And Rituximab knocks those out. But it also knocks out your good B cells. And what good B cells do is helps you make antibodies. So we know that patients who have gotten Rituximab often are not making antibodies to the COVID vaccination. So what every oncologist has been fraught with is trying to figure out how do we protect our patients and try to get them vaccinated and keep their mantle cell from coming back at the same time. Current recommendations are you have to be off Rituximab for 6 months before your body will make an antibody to the vaccination. So, yes, COVID has changed everything because I've held maintenance Rituxan in patients for 6 months to allow them to get vaccinated. In other cases, I've had to give Rituximab for patients that absolutely need treatment, knowing that they're probably will not respond to the vaccination. The vaccination won't hurt them, but they're likely to not make an antibody to the vaccination. So COVID's been horrible, and we all are just struggling with kind of balancing the risk of the disease versus the risk of COVID. And part of that is also, where do you live? What's your vaccination rate in wherever you might be, and how much COVID risk is in the area that you're in. So it's been a real struggle. And I think you mentioned early, Jesse, that you now have, that the Lymphoma Research Foundation actually has some COVID materials or a website with information. Is that right? I think you said that in the...
Yes, we do. So you can access that online, and that'll have some of our archived webinars, and it will tell you when we have upcoming webinars, and it'll have all the kind of up-to-date CDC information as well as some publications, like a white paper that we did. So yeah, it's always good to check in directly because, as you just said, there's so many updates daily, really.
They are daily, and actually one that I'm excited about is last weekend, Dr. Fauci finally made, kind of publicly recognized that a lot of our patients with cancers who've been treated, or immunocompromised patients who've had transplants, or patients with autoimmune diseases, many of those are not responding to the vaccination, not making an antibody response. And the CDC is actively working on recommendations of what we can do for those patients. Do they need a booster? Do they need, if they got Moderna before, do you need to use Pfizer? Do you use one? Do you use two? Do you use J&J? So hopefully the CDC will be coming out with some recommendations hopefully in the coming months about what we can do for our patients that did not make antibodies to the vaccination. So go ahead.
That'll be a great update. Our next question, someone just had, I know you kind of briefly mentioned scans in the beginning, but someone just wanted to clarify when a PET scan versus CT scan is used, and at what point can scans be stopped after treatment?
I see that question in front of me, and that's an excellent question, Ms. JP. And so it's actually an easy question to answer. PET scans are used to stage patients and to define a complete response. So they're essentially used during treatment. If you've ever seen a PET scan, you'll also know that normal things light up on a PET scan. So your lymphoma lights up on a PET scan, but so does your heart or your bowel or a pneumonia, an infection. Normal things light up on PET scans also. So PET scans are great to figure out if your lymphoma's gone, but the trouble with PET scans is they're not recommended to be used in surveillance. Once you're in remission, it's recommended to use CAT scans, and that's not because the insurance company's being stingy. It's not because PET scans are too expensive. It's because PET scans have been proven to pick up a lot of red herrings or false leads, like something will light up that's not lymphoma, and it ends up to it with another scan, which means more radiation exposure to the patient, or a biopsy, which could be add morbidity to the patient. And so PET scans are great, and they're great at defining a complete response, but the downside of PET scans is a lot of things can light up that turn out not to be lymphoma, which leads to potential harm for the patient. And so it's been proven that in surveillance, if you use CAT scans allow you very easily to measure things specifically, even better than PET scans. They don't light up the way we all like looking at a PET scan, seeing it light up and then not light up. Like there's some amazing sense of accomplishment that makes us all feel good when a PET scan goes negative. But a CAT scan allows us to measure things, and if things are increasing in size, if a lymph node's increasing in size, if the spleen is increasing in size by measurements on a CAT scan, then you can be worried that the mantle cell lymphoma might be growing, and then you can get your PET scan to confirm that. But PET scans, recommendations are used, PET scans are during treatment, CT scans are used during surveillance. Hopefully that answered those questions. How long do we use CT scans? That's a really hard question, and that varies from provider to provider. You know, we worry that in most patients, mantle cell lymphoma will eventually come back, which means that we probably need to watch patients indefinitely for the rest of their lives. Some institutions do annual PET scans on all of their mantle cell patients. I've seen institutions do them just every other year, especially if a patient has no other symptoms. Obviously, do a CAT scan if there's concern for relapse. But there's no standard of care across the board. I tend to do them annually unless a patient's really young. You know, if I have a 40-year-old with mantle cell, you don't want to be doing a CAT scan on that patient for the next 40 years. That's a lot of radiation. So you just have to kind of tailor it to the patient and the situation. A more aggressive disease, a mantle cell, you might want to do once a year. A less aggressive, you might talk about it. I always talk about it with my patients, and we kind of agree together what we're both comfortable with, because we know that radiation itself has its own downsides. So, okay, that was my long-winded answer to that.
No, that was great. I think we have probably maybe time for 2 more questions, if that sounds good to you.
Yeah, I see some here that I'd love to address, if you don't mind.
Yeah, please. Go for it.
Only because I don't know that I can see all of them. They're actually the ones that are at the top of my list. Dr. Fagan, I'm sorry, I don't think I should have said your name. My apologies. But he actually emailed me this question, too, so I want to address it. And the question was, can you please discuss the approach to CNS extension of mantle cell lymphoma? And that is, so mantle cell lymphoma, what the question is mantle cell lymphoma usually affects the bone marrow and the lymph nodes and the spleen, but occasionally it can affect the central nervous system. It can move into the brain, or more commonly into the fluid around the brain called the cerebrospinal fluid. And the approach to it when it's in the cerebrospinal fluid traditionally is to use small amounts of chemotherapy that you actually put into the cerebrospinal fluid through a spinal tap. That's one approach, where you just squirt a tiny bit of chemotherapy into the fluid around the brain to kill those cells. Or use a drug called high-dose methotrexate. And the high-dose methotrexate can actually cross from the blood into the brain and kill the lymphoma that way. Having said that, we know Bruton and Venetoclax both do penetrate into the brain. So those are the new novel agents. Bruton and Venetoclax have CNS penetration. So at least in CLL, we've used them to help with patients who have CLL in the fluid around the brain and the CSF. And that is definitely not FDA approved, but if high-dose methotrexate doesn't work, then I would probably move towards some of these novel agents that we know actually can get into the brain, and you might have some success there. So that would be my answer to that question. There was another question I wanted to answer about a patient who received hyper-CVAD who's still in remission. Congratulations. And I didn't spend a lot of time on hyper-CVAD, so I wanted to answer this question. I used to use hyper-CVAD a lot, so congratulations. I had great response, great responses with it. The reason it's not used as much anymore is twofold. One is it was proven to be more toxic. If you went through it, you know it's a pretty aggressive chemotherapy regimen. And it turns out that essentially, think of it this way, you're kind of trading toxicities. If you get hyper-CVAD, you get your high-dose treatments up front with the thought that you don't need the transplant then because you've already been through pretty strong treatments. That's one reason. It was never intended when it was developed by MD Anderson to be followed by a transplant. They developed it to be used alone as a therapy. The second reason is that studies showed that it's very hard to collect stem cells after somebody's had hyper-CVAD. And so that's another reason that you would not have gotten a stem cell transplant after receiving hyper-CVAD. And then the end of that question is, at what point, how many years would I be able to say I'm cured? Unfortunately, we don't know. We talk about long-term remissions in mantle cell lymphoma because we just don't know if people are really cured. We think with transplants, Allergenix transplants from other people, that they can be. But, you know, mantle cell can still come back many, many, many years later. So, boy, I hope you're cured. I hope every one of you out there is cured in some way. But, you know, we can't use the word cure yet, unfortunately, because it can come back late. And those are the questions I want to answer. What else do you have, Jessie?
We just have, I think for one of our last questions, if you just, that woman who had asked before about Cyclin D1, she clarified her question a little bit, so I'll just read that off. Just, does anyone with Cyclin D1 rearrangement always have active disease, or could it just be a marker that they could come down with mantle cell lymphoma in the future?
Boy, I know that Cyclin D1 can be expressed in other lymphomas. I do not know of cases where Cyclin D1 is expressed outside of some type of lymphoma. I'm not aware of it, but it's also not my area of expertise, and I don't know. I don't know the answer to that. I'd actually look that up.
Okay. Well, thank you so much. And this is it might be a difficult question to ask, but I think it's a good one to end on, and I know you talked about it a bit at the end, but is there anything on the horizon that would look towards a cure in mantle cell lymphoma? Or, you know, you can rephrase that kind of however you feel is best.
Yeah, so, I mean, we are really, allogeneic transplant can cure. We think it can cure, but it has toxicity, so that's always one option. But, there's so much on the horizon, and I didn't get to talk about it, but so CAR T cells, we don't know if it's too new. We are hoping they might cure some patients, but it's even in other types of lymphomas where it's been used, where CAR T cell therapy has been used for, you know, a few years now, we're still not sure that those patients are cured. Well, we're hopeful, but we don't know for sure. But there's a lots of variations on CAR T cell therapies, like NK cell therapies, allogeneic CAR T cell therapies. So CAR T cell is just kind of the first generation of that kind of therapy, and there's going to be variations coming down the pike within the next years, in the short years, not long years, that there's just a lot of hope in that regard as far as we really might have some cures for a lot of patients. Yeah. So yes, there's a lot of hope for a cure.
Great. Well, thank you so much, Dr. Bengtson. You've, you know, really given us so much of your time today, and I know we had some great listeners who stayed on and were really interactive. So I just thank you so much for joining us today.
Well, it was my pleasure, and I just want to thank you for the opportunity, and I just want to wish the very best to all the patients and caregivers out there. I just hope you all do really well, and I hope this was helpful to you.
Great. Thank you. And we'd also like to thank our sponsors again for making this program possible: BeiGene, Bristol Myers Squibb, Kite Gilead Company, Lilly Oncology, and Pharmacyclics and AbbVie Company, and Janssen Biotech. Please remember, if you have any additional questions or you'd like to be connected with someone else who has been impacted by lymphoma, you can reach out to our helpline at 800-500-9976. At the conclusion of this program, you will receive an email prompting you to complete a program evaluation. I'd ask you please take a few moments to complete this, as they are very important for helping us to ensure that we deliver the most useful and meaningful programming to you. And with that, I'd like to thank you all for joining us, and have a wonderful day.